Welcome, and thank you for your interest in our RSNA Case Collection presentation, Traumatic Diaphragmatic Rupture. My name is Sylvan Krause, and I am a fourth-year interventional radiology resident from Maine Medical Center. And I have here Sean Callow, a current transitional year resident going into diagnostic radiology at Case Western Reserve University Hospitals. Our patient is a 91-year-old female who presented to the emergency department hypotensive after a high-speed head-on motor vehicle collision. Initial AP chest radiograph shows multiple loops of gas-filled bowel within the left hemithorax, denoted by the black arrows, with rightward mediastinal shift highlighted by the yellow arrows. Note the displaced left rib fractures in the white rectangle. Axial contrast-enhanced CT through the chest shows multiple dilated loops of small bowel with air fluid levels denoted by the black arrows and significant rightward mediastinal shift marked by the yellow arrows. Coronal reformatted CT image of the chest shows a defect in the left hemidiaphragm with loops of dilated small bowel herniating through the defect demonstrated by the black arrow. The small bowel mesentery has an hourglass appearance as it traverses the diaphragmatic defect, which is referred to as the collar sign marked by the white arrow. Sagittal reformatted CT images of the chest shows the herniated small bowel traversing the diaphragmatic defect, as shown by the black arrows, with several loops layering dependently against the posterior thoracic wall, also referred to as the dependent viscera sign, denoted by the blue arrows. The collar sign is again noted by the white arrows.
The final diagnosis is traumatic diaphragmatic hernia. This is supported by the patient's recent history of high mechanism trauma, physical exam findings, and multiple imaging findings. The imaging findings include the primary diaphragmatic defect or dangling diaphragm sign. Additional supporting signs are the collar sign and the dependent viscera sign. As we can see on the left intraoperative image, upon initial thoracotomy, the viscerated loops of small bowel were contained within the left hemithorax. The image on the right shows a 5-centimeter defect in the anterior left hemidiaphragm, which was revealed after reduction of the abdominal contents. The top differential diagnoses for this case include Bactelic hernia, Morgagni hernia, and eventration of the hemidiaphragm. In the case of a Bactelic hernia, prior imaging shows chronically herniated abdominal contents within a posterior lateral diaphragmatic defect, typically on the left and without adjacent fat stranding. A Morgagni hernia would have a similar chronic appearing defect. However, it is usually located in the anterior diaphragm through the foramen of Morgagni and on the right side. Eventration of the hemidiaphragm is a congenital or acquired thinning of the hemidiaphragm, which presents as a chronic focal elevation of the affected side. The diaphragm in this case is intact. It's important to note that all these differentials include chronic findings not typically related to a patient with a recent history of trauma. 0.8 to 1.6% of patients presenting to the hospital for blunt abdominal trauma involve TDH. A majority of these cases involve the left hemidiaphragm, which is less protected than the right. Affected patients may present with marked respiratory distress, decreased breath sounds, and presence of bowel sounds on auscultation of the chest. Concurrent injuries such as rib fractures, pneumothorax, lung injury, and solid organ injury, among many others, are common. Multiplanar CT for TDH has a relatively high sensitivity and specificity in the range of 71 to 90% and 98 to 100% respectively. Disruption of the diaphragmatic contour, herniated intrathoracic bowel loops, collar sign, and dependent viscera sign make up some of the many imaging findings. In these cases, it's important to look for concurrent solid organ or hollow viscous injuries. Treatment involves resuscitation, management of airway, breathing, and circulation, and stabilization of the patient. Definitive treatment is surgical repair, typically with suture or mesh flaps for larger defects. Prognosis is favorable for isolated TDH, but increases to 14.7% in cases with concurrent intra-abdominal injuries. We would like to thank you again for your interest in our presentation, and thank you to our Deputy Editor, Dr. Christopher Walker.